thanks everyone for coming. Really appreciate you guys giving up your busy weekends. And I know you've got psych assignments, GP assignments, PEDS assignments due, so thanks for coming, much appreciated. For those of you who don't know me, my name's Matt Dunn. I'm a fifth year, I'm a postgrad from Sydney. Really like psych. It's the only thing that I enjoyed last year. Fourth year is a really difficult year, so you have to find things that you enjoy from it, because otherwise it'll break you. Yeah, it will. Trust me, it almost broke me. It didn't, but the good news is you guys are already halfway through, so give yourselves a round of applause. Woo. Good. Yeah, and the exams really aren't that bad. They're getting fairer, and they're getting, I guess, more kind, because they know that it's a very stressful time for us. So without further ado, I'm going to start on the mental state exam and psychotic disorders. So this is what I'm going to cover today. I'm going to cover the mental state exam using the great Ben Amberg's aseptic acronym, or mnemonic, whatever you want to call it. Then I'm going to cover the psychotic disorders. However, the psychotic disorders aren't limited to the disorders of the schizophrenia spectrum. That's just what I'm covering today, okay? So it can also include like medication-induced psychosis, and also you can get major depressive disorder with psychotic features. I'm purely covering the schizophrenia spectrum. And then I'm going to talk about an approach to a first episode psychosis, because I think that would be actually a really good and really straightforward OSCE station. Person comes in, you've never met them before, the hospital's never met them before, and they're clearly psychotic. Please take a history, investigate them, and manage them. So we're going to run through that. Excellent. Okay, so the mental state examination, with thanks to Ben Amberg. He's such a jet, by the way. Love his notes. You should use them. So the mental state examination is the psychiatrist's version of a physical, okay? It's an objective assessment of the patient's psychiatric state, okay? And the reason that they do it is because it means that if I do an MSE and you do an MSE, they should be comparable. Versus if a patient tells me they're sad, they might tell you that they're, I don't know, like less sad or happy, and that's subjective, so it's different. Whereas the mental state exam is objective. It's important to report on what the patient is currently experiencing. For example, in a patient who's a chronic schizophrenic or has like long-term schizophrenia, if they were hallucinating 6 years ago, but they're currently not hallucinating, report the fact that there's no current perceptual disturbance, okay? Doesn't matter what happened in the past. It's also okay to say unable to assess. And that's very important for us because, or you guys, because in your OSCEs, you're not going to have to do it with a patient sitting in front of you. It'll be a video, watch the video, and then report back or do something with it. And so they're not going to do insight, they're not going to do judgment, they're not going to do cognition. They just won't. So you can say unable to assess insight, judgment, and cognition. That's okay. Cool. Or well, any of them for that matter. So aseptic stands for appearance, speech, emotion, perception, thought, insight, and cognition. There's lots of different acronyms and mnemonics, just memorize one. But they all essentially cover the same things. And you should always mention rapport. And the reason that you should mention rapport is that if you have a good rapport with a patient, it means that your objective assessment of their emotional state is reputable, okay? Versus if you have a shit rapport or like a bad rapport, it means that like there's not that much evidence behind your mental state exam and it's kind of not really valid. So it's good to mention rapport. Cool, appearance, A. 3 things you want to describe: how they look, what they're doing, which is their behavior, and what their motor spectrum is like, okay? Just with physical appearance, I've heard conflicting things. The way that you should describe someone is you should describe someone so that you can pick them up off the street. However, you don't want to be super inclusive. So if you were describing my physical appearance, you'll say that Matt's a 24-year-old man who looks younger than his stated age. He's wearing full black, okay? You could easily pick me off the streets there. He has long hair, he's Anglo-Saxon, or he's white skin. Cool. Physical features such as body habits, tattoos, and scars, if they're relevant, okay, particularly like obesity is a big one because, like, again, patients on those long-term antipsychotics, they develop the metabolic syndrome, so that's important. Clothing's important for a few reasons. If it's brightly colored, it could suggest mania, and they will do that. They'll put like that's very easy to simulate in an OSCE. They'll get a patient to wear like a brightly colored shirt, and then they'll get them to sit in front of you. Poorly kempt or disheveled can happen in chronic schizophrenia, and mismatched clothes, that's kind of a sign of depression because the patient kind of loses their, like they don't really care about their appearance anymore in chronic depression. Personal hygiene is important, obviously, as well. Behavior, what is the patient doing? So Matt is currently standing at the lectern, he's maintaining good eye contact with the audience, yeah? His attention is focused on what he is doing in front of him, he's not distractible, he's not hallucinated. Nice and easy. And is he cooperative? Yeah. Motor, a few things you want to describe. You want to describe the motor spectrum, and this is all the way on one extreme for agitated and angry patients running around and lashing out, all the way through to the other end of stupor. Stupor means essentially that the patient's like a statue, okay? And we see stupor in catatonia, which is in itself a syndrome. It's a motor syndrome that we're going to cover very shortly. Okay. Also comment on the presence of any extrapyramidal side effects, which are caused by the, or more commonly caused by the first-generation antipsychotics, and also the presence of any stereotypical movements and tics. Just as an aside, if you're doing a cardiovascular examination and you don't see the presence of a sign that's not relevant to the differentials that you're looking for, you don't report it, okay? The same thing for the mental state exam. If something's not relevant, for example, if a patient's got a depressive disorder or you think is presenting with like an affective disorder, it's not really relevant to present on whether or not there's stereotypical movements and tics. And the only way you can pick that up of what's relevant and what's not relevant is through actually doing a psychiatry placement. Okay, so if you haven't done it yet, don't worry, you'll learn how to do it. In the same way that you learn what the relative positives and negatives are when you feed back to your cardiology consultants in a patient with chest pain. You just learn what's relevant and what's not relevant. Speech. When you're assessing your patient's speech, temporarily ignore what they are saying and focus on how they are saying. So if you're listening to a song, ignore the lyrics, and just listen to the music in the background. So what things do you comment on? You comment on how loud the music is. You comment on the tonal variation in the music. If you're listening to my speech now, you'll notice that there's like a bit of tonal variation in my speech. And we call that prosody, the musicality of speech. So patients with chronic schizophrenia and even like in depressive disorders, they can lose that musicality, lose that prosody of speech. It's important to present on that. Also comment on the rate and the presence of any accents or any slurring, which might suggest that the patient's had a stroke or has dysphagia, like normal sort of things. Importantly, pressured speech is a disorder of thought stream, and it should be reported under thought. It is not a disorder of speech. It's very confusing. However, what is pressured speech is what? Mania, yeah? Patients talking quickly, it's difficult to interrupt. So you would also report that as a rapid rate of speech because they have a rapid rate of speech. However, you would then also say that it's pressured under thought stream. Make sense? And we'll cover that later. Good. Good. Emotion, two things. Mood is simply how the patient is feeling. So they'll tell you, doctor, I'm feeling sad. Simple. Patient says they're feeling sad. And you can actually put it in like little quotations. Affect is your objective assessment of what the patient's emotional state is, okay? And there's a few things that we want to describe when we're describing affect. Quality, range, reactivity, mobility, appropriateness to the situation, and congruency to mood, okay? Quality is easy. It's just it's just like the overall type of the affect. So my affect now, you might say, is a little bit euphoric, maybe euthymic. I'd probably go with euphoric at the moment. I'm feeling pretty good. A little bit manic, that's good. But it can be anything from anxious, irritable, suspicious, doesn't matter. It can be anything, just whatever you think their emotional state is currently. Range is a bit tricky, okay? In the next 45 minutes, I'm gonna go through a series of emotions from euphoric to euthymic, maybe a little bit annoyed if the computer stops working, or when I'm talking about schizophrenia later on and how it's associated with suicide, I might get a little bit of a somber affect, and that is normal. It is healthy to go through a range of emotions, okay? If, say, for example, I only went through one or two emotions, you would describe my range of affect as restricted, okay? The overall quality of the affect is what they're primary in. So I might be euthymic for the majority of it, or I might be depressed for the majority of the consult. However, I might also be happy at times, and in which case I'd have a normal range. Does that make sense? Yes, so quality is what they're predominantly presenting as, and the range is then whether or not there's other effects in there. Importantly, you can't have an increased range. You can't make up emotions, okay? There's only a set number of emotions that humans can have. What you were referring to if you said that a patient has an increased range is you're trying to say that they, in that 45-minute consult, went through a wide variety of emotional states. And that's more appropriately reflected as mobility, which we'll cover very shortly, okay? Two special terms. If a patient has a euthymic affect, which means normal, and the range is extremely, extremely restricted, maybe to only one or two emotions, we call that a blunted affect. It's a special term. So it encompasses both the quality and the range, yeah? If the affect is so restricted that they're only displaying a euthymic affect, we call that flat affect, okay? So blunted and flat are basically the same thing, just the flat is just a more extreme form. It's more restricted. Make sense? Excellent. Good. And those two, whenever you use the term blunted or flat affect, only use them when you're referring to a patient with schizophrenia. If you say blunted affect, the psychiatrist's ear will perk up and think, okay, they're talking about schizophrenia, or they're talking about a disorder of the schizophrenia spectrum, okay? Don't use it in a depressed patient. Good. Okay, reactivity. Does the patient's affect change based on how you were talking to them? So say, for example, you might ask them to tell them, you might ask the patient to talk about their mother. And say, for example, their mother passed away recently and they get a little bit sad about that. That reactivity is normal, Okay, but say for example it didn't change, you report that as low, or if it was really overreactive, you present that as high. Okay, mobility is how quickly do they cycle between those affects, and if they are cycling between affects very quickly, you report that as labile. Yeah, the range would still be normal because there's only a set number of emotions that humans can experience. You can't make up emotions, but you would describe it as labile. They're flicking between affects very quickly. Appropriateness is different to congruency, and people get confused with this. I did. You specify that you're talking about how appropriate their affect was to the setting. So if you're talking about like something sad like 9/11 and the patient's laughing, that is inappropriate to the setting or the topic of the conversation, okay? That's different to congruency. The congruency refers to, does the patient's affect match their mood? And if, so say for example, they're laughing and carrying on, but then they say, I'm really sad. Well, that doesn't make any sense. The affect, the euphoric affect is incongruent to their dysphoric mood, okay? It's different to appropriateness. Cool, perception. I couldn't really find a definition of perception. So perception is just basically the way that we've, yes, question, excellent. So reactivity, okay, so reactivity is, so I'll ask you a question about your parents, and you might be like, oh, my parents. You're reacting. Your affect is changing based upon what I'm asking you. But say, for example, so like reactivity is basically your response to a question that I'm asking you. Appropriateness is just how your affect is in terms of the topic of the conversation. It's different. It's whether or not it's appropriate. So if you started laughing about your parents, that's an appropriate sort of response. I hope I answered that correctly. I don't think I did. Yeah, I don't really have time to go through it, but come ask me afterwards and I'll chat you through it. This is difficult, okay? This is difficult. People struggle with this. So it's okay, just read it over and over again, eventually you'll get it. So perceptual disturbance is a disorder in the way in which we perceive things around us. Okay, I know that sounds silly because I'm using the term and the definition again, but that's just the way that you need to consider it. And the 4 key perceptual disturbances that we need to cover are hallucinations, illusions, misidentifications, and dissociations. And I flipped the order of the slides around here, so flick 2 through. Okay, so a hallucination, I don't really want to walk away from the mic, but say for example, this is Fred, okay? I can see Fred here, Fred is here, okay? I'm touching Fred right now. There is no object to the perceptual disturbance. It is automatically a hallucination, okay? Versus, this is Fred. Look, I'm touching Fred. I'm patting Fred's head. For those of you at home, I'm currently patting the computer. There's an object, okay? It can't be a hallucination. So it's either an illusion or a misidentification. If you in the front row then say to me, Matt, you're an idiot. That's clearly a computer. And I go, oh, crap, you're right. It's correctable and it's an illusion. Illusions are normal and they can happen in normal people. It happened to me this morning when I woke up and I thought that the towel hanging over my door was like a shadow in my room. And it took me like a minute to wake up and realize, no, that's just the towel, you idiot. No one's in your room. It's normal to have illusions. Hallucinations are abnormal and they happen in psychotic disorders, okay? The exception being visual hallucinations, which are more likely to be organic than like a disorder of the psychotic spectrum, but we'll cover that very shortly. And misidentifications are classic in patients with dementia. I don't know if you have any grandmas or old aunties who make mistakes like that all the time, but they're very argumentative. You try to correct them when they call your brother Andrew Simon, like, no, that's Simon. I'm convinced that's Simon. It's not correctable. You can't argue with them. Good. So a hallucination can occur in all 5 senses. In the disorders of the schizophrenia spectrum, the most common by far is auditory hallucinations. And if you get an OSCE with a psychotic patient, it will be an auditory hallucination, guaranteed. Visual hallucinations are organic until proven otherwise, okay? So you need to rule out delirium tremens, which is technically an organic disorder, and that's due to alcohol withdrawal, and also Lewy body dementia. They're your 2 classic conditions in which you can get visual hallucinations, and they're both organic. Okay, if a patient does have auditory hallucinations, you want to know a few things. You want to know, is it inside their head or is it outside their head? If it's inside their head, it's more likely to be their own thought and less likely to be a hallucination. Versus if it's on the outside, then it's more likely to be a hallucination. If I'm a male and I can hear a female voice inside my head, that's more likely to be a hallucination. So the gender of the voice is very important. If they know who the voice is, so say for example, I can hear Brad Pitt in my head, that's clearly not my own voice that I can hear in the back of my head. Things like this, you want to distinguish between whether or not it's their own voice or if it's someone else. How many people there are, what are they saying, what are they doing, and that's very important, particularly if you're a risk assessment, because if they're having command hallucinations to go kill their family, that's obviously very, very important, and you want to present that in your risk assessment. Good. Thought. Whenever we think, there are 3 components to us thinking, okay? There's the thought stream. How quickly are the thoughts cycling between our heads? There's the thought also cycling within our head. There's thought form. How are those thoughts joined together? And finally, there's thought content. What are we thinking about? And that's how you need to break up the disorders of thought into those three components. Okay, so here, thought stream. How quickly are the thoughts cycling through our head? And you report that as either slowed thought stream or increased thought stream. This is also where you report pressured speech as a disorder of thought stream. So someone with pressured speech will have an increased rate of speech. They will also have an increased thought stream. And finally, they will have pressured speech. Does that make sense? The form of thought disorders, so a disorder in the way in which our thoughts are linked, we'll cover very shortly. But when we're talking about thought content, there's two things we want to cover. What is the theme of what they're talking about? And finally, are there any pathological thought processes? So the theme can be anything. It's basically whatever the topic of the conversation focused on. We said before about their family. So the patient talked about themes of their family and how much they missed their family. It can be anything, it doesn't matter. But the pathological thought process that we want to talk about are delusions, overvalued ideas, and obsessions, yeah? So what's a delusion? A delusion is a fixed false belief that cannot be reasoned with and is outside the cultural norms. And the reason that there's the outside the cultural norms component is because we quite rightly don't want to drag religious people into this topic. That's just not fair. It's not what we're about. And there's hundreds of different types of delusions. I've just listed the most common ones here. You need to go in your own time, find your buzzwords document. I'm sure you've all got one, and just like memorize all the different types of delusions. The ones that I've seen that come up that people might not know of is this. I don't even know how to pronounce it. Autochthonous delusions. And the buzzword is they just came out of nowhere. It's one of Presnell's classic EMQs. People sometimes get confused with the difference between thought blocking and thought withdrawal. Thought blocking is a delusion in that, okay, I'm talking and then halfway through the middle of a sentence, my thoughts are just sucked out of my head. You just lose the thoughts, okay? Thought withdrawal is you in the front row are actually pulling the thoughts out of my head. See the difference between the two? And Presnell will always put those two in, thought blocking and thought withdrawal, as an option. So just make sure you know the difference between the two. Okay, what's the difference between a delusion, an overvalued idea, and an obsession? Well, a delusion we already know is a fixed false belief that cannot be reasoned with. An overvalued idea is somewhat of a step down. It's still a false belief, but it's not held with absolute conviction, so it can still be reasoned with, okay? And an obsession is even a step down below that, and the patient knows that it's false. I know that washing my hands hundreds of times isn't going to get all the bugs off them, but I just have to do it anyway. It's ego-dystonic. It's not acceptable to my ego. It's making me uncomfortable that I'm doing this. Makes sense? They're just steps down. Cool. Okay. The form of thought disorders refer to, as we said, disorders in the way in which our thoughts are joined. Okay. So the connections between our thoughts, there's a problem with that. And unfortunately, there's not really a unique set or a universal set of terms that every psychiatrist uses. So the terms that I put up here, you will find a psychiatrist who disagrees with them, and you'll also find a psychiatrist who agrees with them. These are the terms that work for me, and I think these are the terms that best work for Monash exams, both using Dr. Presnell's impression of it and using Dr. Sarah Rotstein's impression of it, because they're your two co-examiners for this year. Yeah. Interestingly, the formal thought disorders or form of thought disorders used to be pathognomonic of schizophrenia, but we know that's no longer the case because flight of ideas can happen in mania. Yeah. So I've only covered about 6 form of thought disorders. You need to go away in your own time and learn all the other ones, but these are the ones that people get confused with. Poverty of speech is confusingly a form of thought disorder, but this is basically when the patient isn't talking much. Okay. They might be giving you very minute responses. So you might say, hey, going like, yeah, I'm good. Very simple, very brief responses. That's nice and easy. Poverty in the content of speech is the same as saying poverty of thought. They're equivocal terms. And this is the patient who's talking in a normal amount, however, they're not really covering too much. It's like verbal diarrhea in many ways. And this we tend to see in patients after traumatic brain injury, which is quite sad. It's just a very specific sort of term. Circumstantiality. This is something that we see in old patients when we ask them, tell me about your chest pain, okay? And so what they do is that they still answer your question, so they still will eventually get back to the point. However, they just provide an exquisitely large amount of detail in the process. I'll give you an example. Okay, so question. Mr. Smith, tell me when your chest pain started. And Mr. Smith says, my chest pain started at 6 a.m. this morning. Question to answer, direct, okay? A patient with circumstantiality will say, well, what do you want to know about my chest pain? Or they'll say something like, well, Sonny, let me tell you about my chest pain. It started this morning when I was walking my dog around the neighborhood, and then a cat ran in front of us, and then I felt this sharp pain in my chest. Okay, they're giving you excessively large amounts of detail, but they're still getting back to the point. Okay, so that's important for circumstantiality. I hope that diagram makes sense. Loose associations, this is another difficult term, and this is where most of the controversy comes from. What is a loose association? Kaplan and Psychotic, and also Psych Light, so Rob Seltzer and Steve Ellen, define a loose association as a deficit in the way in which the thoughts are connected. There's a loose association between the patient's thoughts, okay? There's two types of loose associations, tangentiality and derailment. Derailment's just a more severe form. So actually, I've never seen a Monash EMQ when they ask you to distinguish between tangentiality and derailment, they'll just say loose associations, okay? And I'll show you diagrammatically what I mean by that. So here we have the question, tell me about your chest pain, or when did your chest pain start? And a normal person goes straight to the answer. A person with loose associations will say, okay, my chest pain, my dog is blue, this is a laptop, my water bottle is full, okay? They will gradually just drift away from the point, and the thoughts in no way, shape or form are linked, okay? Loose associations. This is different to flight of ideas. Flight of ideas is a form of thought disorder in which the thoughts change pace very quickly. However, when they do so, they are still connected in some logical way. So there's still a connection between the thoughts. In the end, however, the point is still lost. Yeah? And this is seen in mania. This is pathognomonic of mania. So if we have our loose associations here where we just drift away from the point gradually, this is flight of ideas. We're still drifting away from the point. We never get back to the point. However, the thoughts are still connected in a logical way. Yeah? And this is literally word for word what your EMQ will be. This is taken directly out of Kaplan's. Yeah? Cool. There's maybe 10 or so formal thought disorders. These are just the main ones. You need to go away in your own time and learn the rest of them. Insight. Does the patient have good insight into their condition? So you need to report whether or not they are accepting of the diagnosis, and almost more importantly, are they willing to go along with treatment? Because if they're not, they're going to need an assessment order, be that as a community as a treatment order or a inpatient treatment order. Okay, and judgment is very simple. You ask a simple question like, if you walked up to a letterbox and you found a letter next to the letterbox, what would you do? And the simple solution is I'd pick it up and I'd mail it. But patients with schizophrenia sometimes lose that simple judgment. It's a really dumb one and it won't actually be assessed in your video. So just say unable to assess judgment. Similarly, cognition, you can formally assess cognition with a mini mental state exam. However, patients with schizophrenia often get 30 out of 30 with mini mental state exams, even though they have like significant cognitive impairment. And that's because their impairment tends to focus on the frontal lobe. So what you should say is that I would do an MMSE and I would also do an FAB, a frontal assessment battery. And the frontal assessment battery targets the frontal lobe. You're not going to have to do it, okay? So don't worry. And also don't forget report. Okay. Anyone got any questions about the mental state exam using aseptic before we move on to the psychotic disorders? Cool, fantastic. Let's move on. So this is difficult as well. For your OSCEs, you should have a definition of psychosis that you can just rattle off to a patient if, say, you're counselling them or counselling a family member on what schizophrenia is. So my definition that I memorised is psychosis is a state of mind in which you have experiences that aren't grounded in reality. And the, I guess, layman's term of that is things seem real that aren't real. Nice and simple, yeah? More formally, psychiatrists define psychosis as an abnormality in one or more of 5 domains. Delusions, which we've already talked about, hallucinations, which we've already talked about, disorganized thinking, and that's represented by the form of thought disorders, which we've already talked about. 4 is a bit tricky, but it's grossly disorganized or abnormal motor behavior, and that can really vary from anything, okay? It can vary from anything from like a childlike silliness through to aggressions, the patient who's got ice-induced psychosis and they're flipping tables up and they're lashing out at staff members, or catatonia, which we see in, well, we don't really see much anymore, but they used to see in patients with chronic schizophrenia. And finally, the negative symptoms, okay? The negative symptoms are super important and you'll soon find out why. So catatonia This is how the DSM defines catatonia. I don't know how clinically relevant it is because we're never going to see it. I think of catatonia as basically a state in which the patient can't really interact with the environment around them, okay? And the classic catatonic patient is the patient who's stupor, so they're frozen like a statue, they're mute, so they're not talking, and they show this thing called waxy flexibility, which is where you lift their arm up and they hold it there, and they can hold it there for hours, and it's extremely uncomfortable. There's all these other signs of catatonia, which once again aren't really clinically relevant because we're never going to see them, but things like posturing catalepsy, so they'll just randomly go stand up in the corner and just stand in these uncomfortable positions. Negativism, when you go to shake their hand and they'll pull their hand away. Stereotypy, which are these like repetitive rhythmic motions. Echolalia, where they like, you'll say something to them like, how are you feeling today? And they'll repeat back to you, how are you feeling today? That's also seen in autism. I think you guys had child psych this morning. Good. And echopraxia, which is the same thing, except they just copy your movements instead of copy what you're saying. Yeah. And there's lots of different disorders in which we can see catatonia. It's not just in the psychotic disorders. What is more important and what now in the 21st century causes the greatest deal of morbidity and mortality in patients with like chronic psychotic illnesses are the negative symptoms. So negative symptoms are things that are taken away and they're not as exciting as the floridly active symptoms like hallucinations and delusions. They tend to be kind of forgotten a little bit. And also our medications are fantastic at treating the active symptoms, but do absolutely nothing for the negative symptoms, okay? So we treat the negative symptoms with CBT. So when you're an OSCE, if you have a psychotic patient or a patient with schizophrenia, don't forget to refer them to CBT because that actually helps with the negative symptoms. Good. And the 4 key ones you should remember are avolition, which is the total opposite of ambition. And you've probably all seen this in your own psychotic patients. So they lose interest in bettering themselves in any way, shape or form. Also, I don't want to stereotype patients with schizophrenia. This is just what they represent as negative symptoms. And not all patients with schizophrenia have these things. Likewise, that diminished emotional expression, which you can see in their blunted affects, blunted and flat affects. Asociality, they lose interest in forming relationships with the people around them. And cognitive decline, especially frontal lobe impairment. Good. So the psychotic disorders, not surprisingly, include those 5 psychotic features. And the difference between them depends on how many of those 5 psychotic features they have and also how long they're there for. So it's a lot easier to memorize those 5 things and just learn how to apply them to these like 6 conditions than it is to learn the DSMs for these 6 conditions. Yeah, it's much easier. So schizophrenia, what is schizophrenia? Schizophrenia is the prototypical chronic psychotic illness, prevalence of about 1 in 200, which means that 2 people in our cohort will eventually, or they might have already, develop schizophrenia, which is scary. It's very, very common. It tends to affect men a lot earlier in their early 20s versus it tends to affect women in their early 30s with a second peak around menopause, which is interesting. 1 in 5 patients with schizophrenia will attempt suicide at some point in their life, and about 10% of them will be successful. So it's important to note that it's not just this psychosis. There's also lots of other mental health comorbidities associated with it. And there's also lots of medical issues associated with it as well. Good. So the classic presentation is a young man who has those classic type A personality traits. They might be a bit weird. They might have difficulty forming friendships. And then all of a sudden they get to their early 20s and bang, they enter into their first episode psychosis where they get hallucinations, they get delusions, they might have a form of thought disorder, etc. We then prescribe them a medication, an antipsychotic, which is fantastic at treating the active symptoms. However, those negative symptoms persist for years and decades, and the patient as a result has a significant amount of functional decline. So that's really what we're worried about now, is the functional decline rather than the active symptoms. And the definition is boring. Unfortunately, you guys just need to learn the DSM. You just have to rote learn it. Rote learn it for all the green conditions. But the DSM for schizophrenia is you need 2 or more of those 5 features present for at least 1 month or less if you treat them with antipsychotics. And at least one of them has to be delusions, hallucinations, or a form of thought disorder. Yeah? In addition to that, it has to impact upon the patient negatively, which goes without saying. And the illness in total has to be present for 6 months. The majority of those 6 months will be, I guess, taken up by the negative symptoms. Because if a patient has active psychotic symptoms, we're going to give them a medication quite quickly, yeah? And they're probably going to be psychotic for hallucinating for a week. But then the negative symptoms remain, and that's the key to making the diagnosis. Good. This basically says that there's not a significant affective component to the diagnosis, and therefore it's not more likely to be schizoaffective disorder or bipolar affective disorder with psychotic features, yeah? And it's not due to a substance or a medical condition. This is just like a dumb thing being like, it's not ASD, but it's too difficult and it's not clinically relevant, so don't learn it. Yeah, cool. The specifiers in DSM are also really dumb. People say that you should learn them for your OSCEs. I never did, and I was fine. But maybe if you have the time, go through and learn them for all the green conditions, because it might just take you from a 16 out of 20 to like a 17 out of 20 in your OSCE. Okay, and the specifiers for schizophrenia are with catatonia, in which you need 3 of those signs and symptoms that we spoke about before, or if they're in a first episode, or if they have multiple episodes. Okay, it's not really clinically relevant though, so up to you guys. However, there are 5 subtypes of schizophrenia that aren't in the DSM, but Monash loves to assess them for EMQs, and they're also not really clinically relevant because most patients we see with schizophrenia now are of this residual type. They have ongoing negative symptoms without really those positive symptoms. It's like they've been in remission. That's because those antipsychotics are so good at suppressing the hallucinations and delusions in the form of thought disorders, yeah? But in general, in the old days, you used to see 2 main types. There was the paranoid type, which was the older female in her early 30s who presents with like delusions of paranoia. And then on the other hand, you had the disorganite type, which was the younger male in his early 20s who doesn't really present with flurriedly active symptoms. They obviously have to be there in order to meet the DSM criteria for schizophrenia, but the key is that they're disorganized. They present disheveled, like really poor personal hygiene, quite like prominent like asociality and avolition. Yeah, catatonic type is obvious. It's with catatonia, and the undifferentiated type doesn't fit into any other category. They're not going to assess you on this one, so don't worry. The MSE findings are very variable, but in general, their appearance can vary anything from that like disheveled and malodorous look that we associate with that disorganized subtype of schizophrenia, right through to people who are very well dressed. I've seen patients with schizophrenia who've come from full-time jobs wearing suits. So we shouldn't really be stereotyping them into the young, disheveled, smelly type. It's highly variable. Behavior, you want to comment on whether or not the patient is hallucinated. So they might be looking around the room or they might be mumbling to themselves. Motor, you want to comment on any extrapyramidal side effects. The motor spectrum, again, can be super variable from agitated all the way through to stupor. And if there are any other features of catatonia that you can recognize, okay? Speech can be monotonous, and that just means that they're losing that abnormal like prosody of speech or that normal tonal variation in their speech. Emotion, again, super variable. However, the one thing to note is that blunted affect or flat affect are synonymous with schizophrenia. So if you say blunted affect to me when you're reporting back an MSE, I know that you're talking about a patient who has schizophrenia. So don't use it in any other setting. Good. Perception, obvious, we've already covered that. The hallucinations are key to like making the diagnosis of a psychotic disorder. Thought, we've already spoken about before. The thought stream may be slowed, and that's often due to the antipsychotic effects rather than the fact that the patient's psychotic, or it could be due to the catatonia if they have a catatonic component. Thought form, the form of thought disorders we've already said, used to be pathognomonic of schizophrenia, but that's no longer the case. And content, we've already spoken about pathology with delusions. Insight can be impaired and judgment can be impaired. How am I doing for time, by the way? What time? Excellent. Okay, good. Okay, so this is important. Patients with schizophrenia can get 30 out of 30 on an MMSE, but they're sitting in front of you like there's something not right here. And that's because they have frontal lobe impairments. They've actually done anatomical studies on patients or like brains, like autopsy studies and also MRI studies. And they found that there's like a volume reduction in the frontal lobe up to about 30%, which is very significant. And what does the frontal lobe do? The frontal lobe does things like personality. So it's not surprising that patients with schizophrenia get these weird type A personality traits. It also encodes impulsivity. So it's not surprising that they're often disinhibited. It encodes executive functioning and complex planning. So it's not surprising that they can't look after themselves in an appropriate way. And the way that you assess the frontal lobe, nice and easy, is you do what I call a frontal lobe assessment, FLA. And I think this could come up on OSCE. It would be tricky, but just learn this and it's nice and easy. F stands for the fluency of F words. So you ask the patient, in the next 60 seconds, I want you to name as many F words as you can think of, and then I'm going to time you. And so a patient who's disinhibited is obviously going to start saying F-U-C-K and all the other swear words starting with F. So it's really good because it tests whether or not they are impulsive or not. In addition to that, the frontal lobe also does working memory. So if you can only get 4 or 5 words out in 60 seconds, it suggests that the patient has something like a problem with their frontal lobe as well. So it's like a double whammy. It hits both. L is Lurie's, and this tests like executive functioning and planning. So you literally ask the patient, hold out your left hand, and then make a fist on the side, and then a palm, just like that. And they won't be able to do it if they have frontal lobe dysfunction. Just Google Luria's. And finally, abstract thinking, because this is also what the frontal lobe does. And you ask this in a way like, you ask an idiom like, tell me what this means to you. People who live in glass houses shouldn't throw stones. And to me, what that means is, okay, if I'm insecure, I shouldn't be picking on other people, something like that, some higher level of thinking. But a person with schizophrenia who's got frontal lobe impairment will tell you, well, if I live in a glass house, I don't want people throwing stones at my glass house because it's going to break the house. See how they just kind of they're losing that extra element of abstract thinking? Really interesting. Yeah, but FLA, it's the way you do it. Good. Okay, differentials in the absence of an affective component. So if a patient is psychotic and there's no significant mood or emotional component to their disorder, the first thing that you need to rule out is a substance or a medication-induced psychotic disorder. This would be a great OSCE, a patient who's come in with like an ice-induced psychosis, okay? The DSM is nice and easy for it. All you need is that substance needs to be able to cause or is known to cause a psychotic illness. And the key ones are methamphetamine hydrochloride, which is ice, thyroxine, corticosteroids, and anesthetic agents. That's it. It's the only four you have to remember. Okay, I'm sure there's others, but they're the ones that I remember. And the second key point is that the onset of that psychosis needs to be like temporarily, not temporarily, it needs to be related to the patient taking the drug. It goes without saying. So they need to take the drug and then get psychotic. They can't be psychotic first. Yeah, it's nice and simple. Or maybe they stopped taking that drug and then they developed a psychosis, which is what happens with the anesthetic agents. You can develop a psychotic illness after emerging from an anesthetic agent. Yeah, cool. So you've ruled out substance or drug-induced psychosis, and you're now thinking, well, is this schizophrenia? Is this schizophrenia-form disorder, or is this a brief psychotic disorder? Okay. Schizophrenia-form and schizophrenia, the DSM are basically identical in the fact that you need at least 2 of the 5 of those things we spoke about before, one being delusions, hallucinations, or formal thought disorders, and those need to be present for a month, okay, or less if treated. However, you differ between them because schizophrenia, the total duration needs to be longer than 6 months. And remember, that 6 months, the majority of that time is spent in negative symptoms. So that's the key, not the active symptoms, the negative symptoms. Brief psychotic disorder, they just need 1 of any of the 5, okay? At least 1 needing to be D or H or FTD. And that only needs to last 1 day. It doesn't need to last a month. So the way you remember it is a month, 1 to 6, and 6 months. You're going to have to go back over this and look at it in your own time because it is confusing, and I hope I've done it justice by summarizing it here. Okay, so what if the patient presents with a psychotic illness, but they also have a significant affective component? So there's a mood component, so they're also depressed or they might be manic. There's 2 things that you need to rule out. This isn't going to come up in an OSCE, by the way. This is too difficult, but it could come up in an EMQ. It'd be a really good EMQ. And your 2 differentials to think of are schizoaffective disorder or major depressive disorder with psychotic features, or bipolar with psychotic features. We'll come back to it. And the way that you distinguish between them is that in schizoaffective disorder, there are delusions and hallucinations, and there must be a 2-week gap in which the patient has delusions or hallucinations with no affective disturbance, okay? That's the key to making the diagnosis. On the contrary, in a patient with MDD or BP with psychotic features, the delusions and the hallucinations exclusively occur during an affected episode. Does that make sense? So it depends which ones, like you just need to relate the timing of the mood and the psychotic disorder. So the DSM for schizoaffective disorder is that, okay, so you need a period in which there's both a mood episode and a psychosis, and the psychosis needs to meet the same criteria for schizophrenia. You need 2 of 5 present for a month, yeah? However, at some point in the illness, 2 weeks, there's delusions or hallucinations with no mood symptoms. Nice and simple. I probably wouldn't go any further than that in terms of schizoaffective disorder. It's not going to come up in an OSCE. It's too difficult. It wouldn't be fair. Cool. Delusional disorder, however, also probably wouldn't come up in an OSCE, but it's fair game for EMQs. And the key to delusional disorder is that they have delusions with nothing else. So it's purely a delusion, no hallucinations, no formal thought disorders or anything. And that delusion doesn't impact them, impact on their life. So the classic present EMQ is like, a gentleman thinks that his work is filming him and they put cameras in the bathroom. However, that hasn't stopped him from getting promoted 3 or 4 times in the last 4 years. So that suggests that whilst he's delusional, it's not like impacting upon his life. Make sense? Buzzwords. Okay, Any questions before we move on to how to tackle a first episode psychosis in an OSCE? Cool. There'll be time for questions at the end as well. So, when a patient first presents with a psychosis, they're labeled as a first episode psychosis because we don't know, well, first and foremost, is this because it's a drug or medication induced? So if you keep them as an inpatient for a few weeks, they don't have access to the ice, the psychosis is going to go away. Okay. You also don't know, is this going to evolve into schizoaffective disorder or a major depressive disorder with psychotic features? Or finally, is this going to become chronic schizophrenia? The good thing about psych is that you can change your diagnosis. They do it all the time. As you see the patient more, as you gain more information, you can change that diagnosis. And in fact, only 50% of patients who are psychotic in an ED for the first time will have a disorder of the schizophrenia spectrum. The remainder of the time, it's going to be medication or drug-induced, ICE, or it's going to be an affective disorder, so major depressive disorder with psychotic features. Yeah? Good. So, however, it doesn't matter. You're going to do the same thing for all of these patients. The first thing you want to do is when you walk down into the emergency department is that you're going to need to assess the need for de-escalation or sedation. Obviously, not every psychotic patient is going to be aggressive. Some of them are very pleasant. They're sitting in the corner knitting. They're just like floatedly psychotic. So, but if they are being aggressive, verbally de-escalate the situation, okay? So ask them what's wrong, introduce yourself, use non-threatening body language, simple things, okay? Then assess the need for a code grey or even a code black if they're being physical or threatening. Yep. If that's not working, you can offer them pharmacological sedation. So offer them, say, hey, look, I can see that you're a little bit irritated at the moment. I could give you something to make you feel a little bit better. If they say no, get stuffed, don't hesitate, go straight for droperidol, 10 milligrams, IM, subcut. But there's a big but here. You have to realize that by doing that, you are restricting a patient's liberty. So it shouldn't be something that is taken lightly. However, it is ethically grounded, providing you're doing it for the patient's benefit or for your benefit, in fact, that you feel threatened physically or for the benefit of the nursing staff. So please never do this lightly. It's a significant thing to, I guess, sedate a patient for being aggressive or whatever. And if that doesn't work, which it occasionally doesn't, you escalate to senior staff and they can do things like give them a dazolam or a ketamine infusion and that will sedate the patient, but very rarely does it have to get that far. If you are giving sedation of any form, there's a few things you want to do. If you're giving IM subcutaneously, you want to get 4 security guards there, 1 for each limb. You need to stand at the head and prioritize the airway, and then you want to get regular 20-minute observations, because if you're giving them droperidol against their will, and then their airway collapses or their code or whatever, you're liable. So you need to prioritize their airway and make sure the patient's okay, yeah, with regular observations. But of course, it's not everyone. I don't want to loop all psychotic patients into the same bag. Good, okay. After that, call a family member. And you're allowed to do that under the Mental Health Act, providing the patient hasn't said, you better not call my wife, you're allowed to call any family member, yeah, providing they haven't stipulated that you cannot call this person specifically. Then admit them to the inpatient psychiatric unit and consider the need for an assessment order and then do a full examination. Every psychotic patient needs a full neuro exam and also like a metabolic screen. And that's to help determine whether or not you're going to give them, like if you're giving them olanzapine and they've got diabetes, central obesity, like you're not going to give them olanzapine. You're probably more likely going to give them like a first generation antipsychotic, yeah? Good. Investigations, there's lots there. I'm not going to go through them. I'll just point out a few key ones. Urine drug screen, goes without saying. It could be like, you want to make sure that this isn't a drug or a medication-induced psychosis. Thyroid function test could be a thyroxine overdose, or it could be hyperthyroidism, because that's one of the conditions that can cause it. Have you guys heard of anti-NMDA receptor encephalitis? Yeah, this is a very topical thing at the moment. They're finding that something like 5 to 10% of patients with treatment-resistant schizophrenia, so that is people who need clozapine, 5 to 10% of them don't actually have schizophrenia. They have this condition called anti-NMDA receptor encephalitis. Ridiculous. So like say anti-NMDA, order lipid profile and blood glucose, and say you would consider ordering an MRI. Some psychiatrists think it's useless. Some think there's a bit of utility in it because you basically want to rule out an organic disorder. Yeah, it's at the top of your pyramid. Have you guys gone through the pyramid today? Good, yeah. Pharmacological management. For EMQs, you need to know specifics of what antipsychotic you're going to give. Like some of them are better for people with like high prolactin, etc. I can't remember which one it is. For an OSCE, you're not really going to have enough time to think like, oh, this patient, I need this, like etc. So in general, just give them olanzapine. Presnell loves olanzapine. 2.5 milligrams per day, titrating up to 10 milligrams as a starting dose, okay? That is providing there's no effective component to the psychosis. If, for example, they're also depressed, your best bet is to go with quetiapine, okay? So either remember olanzapine if they're not depressed, quetiapine if they are depressed, yeah? And then what you want to do is you want to wait 3 weeks. If there's an insufficient response, increase the dose. Once you've given it a full 6 weeks, change to a different antipsychotic, anyone, doesn't matter. Repeat it. If again after 6 weeks it hasn't, nothing's changed and the patient's still thoroughly psychotic, you call it treatment-resistant schizophrenia and you start them on clozapine. Did you guys do clozapine counselling this morning in your first session? Yeah, you should learn how to do that. That would be a really good OSCE station. And in addition to that, if it's an affective psychosis, so like they're depressed or they're manic or whatever, treat it like it was bipolar. If it's bipolar, give them lithium. If they're depressed, start an SSRI. So that's just good practice. Giving a patient with schizoaffective disorder quetiapine and escitalopram is good practice and common practice. Yeah, good. Each step along the pathway, make sure you assess adherence because chances are they don't actually have treatment-resistant schizophrenia. They're probably just not taking it because they've got poor insight. Yeah. Consider the need for a depot as well, like a depot antipsychotic. So that means that you know the patient is getting their antipsychotic. Therapy lasts for at least 2 years, but probably lifelong, okay? The 2 years part is for patients who have like a clear drug-induced psychosis. So give it for 2 years, then you can stop it. But for patients with schizophrenia, it's lifelong. Cool. Finally, you want to optimize the patient's functioning. And I think this is actually where you're going to get most of your marks on an OSCE. CBT for the negative symptoms, follow them up regularly for the extrapyramidal side effects and also for the metabolic syndrome. Try to get them to stop smoking and refer to any sort of community services that you can think of. Anything. Social workers, great. Allied health, great. Anything. Doesn't matter. Just say it. You'll get marks. Finally, there is some utility for ECT in the psychotic disorders. I'm not aware of what it is. I just know that I've seen it used before, so you can think, and potentially consider the candidate for ECT. Done. Nice and straightforward. Okay, shameless plug time because I think we're getting in towards the end. Myself and a few other fifth years run a Vespa every Monday and Tuesday night out of MMC. You guys should come along. I think most of you are probably already in the Facebook group. It's called Vespa, but I hope to see a few more of you there next Monday and Tuesday. Well, I'll let you know what day it is. Any questions? Yes. Fantastic question. So, say for example, there's a patient over here who has an extensive family history of schizophrenia, and they've started showing signs in the prodromal stage, like they're going to develop, so they've started displaying some like type A personality traits, they've become reclusive and stuff, but they haven't yet hit that first episode psychosis. We withhold antipsychotics until that first episode. So no, you don't give them pharmacology, but what can you do? You can do CBT. Excellent question. So prodromal schizophrenia, you use CBT. So they haven't yet hit that first episode psychosis, but you're pretty sure they're going to because of that extensive family history. Great question. Yeah. It's an excellent question. Yes, it does. Well, there you go. Yeah, good. Yeah, providing there's negative symptoms. Yeah, good. Yeah. Yes. So if somebody has all the major depressive disorder symptoms, say previously, and then they get schizophrenia symptoms, you say that they have schizophrenia and they have major depressive disorder? That's an excellent question. So that's why I don't think it's going to come up in an OSCE, because it's technically, if we go back to the schizoaffective disorder, there's also this point here that the mood disturbance needs to be present for the majority of the illness. So say, for example, if you're psychotic for, 10 years, and then 4 weeks of that time, you get a major depressive disorder, or you get a major depressive episode, the diagnosis isn't schizoaffective disorder because it needs to be present for the majority of the illness. And the correct diagnosis is schizophrenia and major depressive disorder. Makes sense? Because it hasn't been present for the entirety of the illness. You can't diagnose schizoaffective disorder. It's too complicated. Yeah, that's why I don't think it's going to come up in an OSCE. Yeah, good question. Yeah, Mazada. No silly questions. So, let's say we do get a schizophrenia and then they're like, yeah. We start with a non-pharmacological, like we want to be like, I would like to do CBT for the improves like the functional component. Or do we start with the antipsychotic? And then mention the good. Okay, so it depends. So this is a patient who's like got floridly active psychotic symptoms. So they're hallucinating. Yeah, okay. You want to start an antipsychotic there and then. Don't hesitate. Yeah, get them stabilized because they're not going to. If they're floridly psychotic, they're not going to respond to CBT. You know, like it's like in depression. The only reason we give patients who are depressed SSRIs is to get them to respond to CBT. SSRIs don't cure depression. CBT cures depression. So yeah, good question though. But you still refer much later on down the line once they're stabilised and once they're taking their medication consistently or on a depot. Yeah, and you got another question. Yeah, go shoot. Yeah, no silly questions, I promise you. Yeah. The question was, would you put a patient on clozapine if they're not adherent? Well, do they truly have treatment-resistant schizophrenia? Well, then, if they've been not adherent, then you can't define it as the treatment-resistant schizophrenia. They need to have 2 good cracks at 2 different antipsychotics, taking the drug every day or taking a depot before you can say, yep, this is a treatment-resistant schizophrenia. Clozapine sucks. It's just a horrendous drug. So you want to like avoid that at all costs. Cool. Yes. Yep. Residual symptoms is in negative symptoms? No. So if the active symptoms have disappeared, then they've responded, because no antipsychotic under the sun is going to touch the negative symptoms. Active symptoms? Yeah. Then it's treatment-resistant schizophrenia and you try them on clozapine. But they are adherent. You give them the depot. Like you can't not adhere to a depot.
Yeah, if they're not adherent to oral, that's why they're not a depot. Then so they only complain because they're on a depot. You can just think back to active.
Oh, that's a good point. Okay, that's a good point.
Because there's too much of a risk of rebound psychosis. Like you really have to be compliant with clothes. So they probably just keep that patient on.
You'd probably need an inpatient admission to get them adherent onto the clozapine. That's the answer. Yeah, or keep, but so they're on the depot and they're responding, like the active symptoms are resolving? No. Well, if they're not, then yeah, that's really tricky. Inpatient admission, keep them on the clozapine. Yeah, so we had a patient when I was on psych who was on oral clozapine and just wouldn't take as an outpatient. So they spent like 3 months of a year as an inpatient because they're not taking their clozapine and they're a danger. Like I think it went to court a few times. Like he was like hanging around schools and stuff. There was a few like police issues and things like that. Yeah. So it's a really difficult decision. And once again, you're restricting a patient's liberty. Yep. How much time? Sorry, how much time do I have, Carl? What time is it? Good. Yep. Depends. So the question was, I thought blunted was pathognomonic of schizophrenia and flat was more common in depression. Depends on who you ask. Depends on who you ask. Yeah. So I would, in fact, if I was you guys, I would just avoid the term flat affect altogether. And if a patient has a euthymic affect with a very restricted range, I'd call it blunted, and then I just wouldn't touch the term flat. Yeah. Yeah. I've asked 2 different psychiatrists that, and they've both said different things. Good point. Yeah. Any other questions? Yes. So they only need 2 out of 5, including 1, 2, and 3 for 1 month. Okay, that's it. Or less if treated, because if they're actively hallucinating for 3 days and you get back on top of it, give them olanzapine, you like, good, you're on top of it. But they still need 6 months for total duration of symptoms, including the residual and the negative symptoms. Cool, makes sense? Yeah. Any other questions? Cool. My email address is on the front of the slides. Please feel free to email me any other questions. Thanks for listening.